Our first study in this domain was on discovering electronic cigarettes being popular, and we showed that 60 Minutes had done a news story on snus, and I'm like, I've never heard of snus. What is snus? Everybody's talking about it. Millions of dollars being spent on the snus pandemic that was coming, where people want to use it. We showed that people were using electronic cigarettes. And so we learned something new. But we can also learn other new things with this. Well, let's see. I got a problem. There we go. Okay, so here's an example of people searching for. We talked about quitting smoking. Here's an example of people searching for how to quit smoking. Each one of these lines is 1 week's of data. Those nodals are the mean for the day of the week. And you can see over time, all across the world, English language searches for how to quit smoking have a peak on Monday, decline throughout the week, and reach their nadir on the weekend. And that's not true just of English. That's true in many, many languages. I think we studied 23. That's every language spoken by at least 1% of the global population. I'll show you 6. That's true in French, Chinese, Portuguese, Russian, Spanish, where the weekend is the trough and the early beginning of the week is the beginning. What day do you think the Tips from Former Smokers or the CDC recommends to do a quit attempt? They say do it on the weekend, encourage it on the weekend, because that's when you have more free time. But that's precisely when the amount of people are thinking about it. Instead, when they're thinking about it, is early in the week, this Monday effect. We can also go beyond seeing like demand for health concerns or problems to understanding specific ideas. This is an example of why do people use electronic cigarettes, using Twitter. And here we can see why they use it, because we looked and we saw people on Twitter who said they used the e-cigarette, and we mined their tweet history to see why they said they used it. You can see a majority of people in 2012 were using it because they want to quit, and that declined over time. And we can see, people use it because they like the flavors, or they can use it indoors, or they think it's safer. Very few people using it because they think it's for low cost, or they're trying to avoid the odor. Very few people. We can also see who has these problems. So we've developed certain techniques to demographically identify who people are on social media, because when you're on social media, not only you tell us what you think, you're telling us who you are, where you live, what your background is, and we can use that. And so here, applying to that same analysis, we can see an example of where people were quitting, wanting to use e-cigarettes to quit or for social image. And you can see that women are more likely to use it than men for social image or for quitting. Men much less likely to report using e-cigarettes for either one of those outcomes. We can also understand, the needs of the public and needs that we wouldn't expect. At a healthcare center, we focus a lot on serving our patient populations, and we understand that many of them may turn to other alternatives like Dr. Google. And so we thought, that's interesting, but what do people really want out of healthcare? They want the human touch. They want to talk to a person. Could they be talking on social media about it? Do people go on public social media and try to get a diagnosis? You've heard of self-diagnosis, physician diagnosis, and JAMA, we coined the term crowd diagnosis with Davey, actually. And so here I'm going to show you an example of it. It's the Reddit forum called RSTD. I'm sure everybody's been on this page at least once today, right? So you can go on there, you can learn anything and everything about STDs. And here we looked at this platform and we saw that, yes, many, many people are using this platform, and its rates are increasing over time. You can see more and more people using it. But why are they using it? It turns out they're using it not only to learn about what's happening, as you see in the first post, but also to get diagnoses for STDs. Help, what is this? Past month, I developed this popple, and then here it is, and I want to know what's going on with it. Can you help me? I want to get a diagnosis. We can see people getting a diagnosis, like in the bottom example. I went to the clinic and got tested, showed HIV-1 confirmation. I have to go back and get another test, but I'm wondering, is the doctor on? Do I have HIV? Trying to get a second opinion, where they're getting an original diagnosis and a second opinion, and we can see them getting those second opinions or diagnoses from their peers, and we can see the time to reply. It makes no wonder why they would be doing this. So here we can see actually that a majority of posts in the bottom panel in B actually were seeking a diagnosis, and nearly all received a reply of a diagnosis. About 1 in 3 people included a picture of the symptoms. You know, you wouldn't expect that to happen on public social media. And about 1 in 5 people were trying to get a second opinion after already receiving a clinical diagnosis from a physician. And so here we see people actually hurting and needing help. Now, this paper initially got desk rejected at JAMA, and I wrote to Howard, the then editor, and I'm like, what's going on? This is pretty important. And he's like, yeah, John, you're right. We got to figure out how to shut this down. You know, we have this top-down model where we go, we know what they need to do. They need to come to us. And we live in a proverbial field of dreams where we assume that they will come to us instead of going to where they are, which is the argument we made with these data was, how do we go and reach these people and help these people who are using online forums in this way? The third way a bottom-up approach can help us is by, fixing missed opportunities. Probably one of the largest missed opportunities, I'm going to skip forward a little bit here, is COVID-19. When COVID-19 happened, of course, we unexpected, and things are going to happen like this, and it's going to be happening a lot. And here we see an example of 2 papers. And I picked these 2 papers for a reason. And that is a paper on suicide from JAMA Psychiatry and a paper on mental health consequences from JAMA Internal Medicine. The first paper was the most read paper ever in JAMA Psychiatry. And what did it have to offer for about the collateral consequences of COVID-19? Opinions. Our top-down model isn't set up to be responsive to when things change. We're not set up to be prepared, as you might say, to how things will evolve and change. And so we couldn't have data, we just had opinion. And so the argument in the JAMA Psychiatry paper was, well, we think suicide is going up. And the argument in mental health consequences was, well, we think people are resilient and there won't be problems with other areas of mental health. But we can actually go to data if we use a bottom-up framework. Here's people going online and searching for acute anxiety, think panic attack. They're having a panic attack and they're like, what do I do about a panic attack? Am I having a panic attack? These types of queries. You can see a huge increase almost immediately after the initiation of lockdowns to slow the spread of COVID-19. We can see search is substantially higher than expected. And so an outcome that our opinion told us, this isn't a priority. It never came up in that JAMA Internal Medicine paper. Actually, no, we could see market effects. And for some people, particularly the younger or healthy, the panic attack would be way worse than even getting infected with COVID-19. Here we see suicides. Now I told you the most read paper in JAMA Psychiatry history said suicides went up, but I'm showing you they went down. Whoa, how do I make it this? John, you might say, I know what the problem is. You didn't pick the right searches. I bet you some things are going up. Well, I'll show you. Here's people searching for, like, if you see at the, how to kill yourself did not go up, painless suicide did not go up, commit suicide did not go up. The things that went up was how many people commit suicide. That search had the largest increase, that specific search. Why? Because people were reading the article in JAMA Psychiatry, of course. Now, how does this make sense? And I'm like, all these experts in the media tell me it should have gone up and it didn't. And I looked into it. Does anybody on the call know if suicides went up or down after 9/11? Does anybody on the call know if suicides went up or down after Hurricane Katrina? They went down in both circumstances. And so there's a literature that actually social support would have increased for people to be diligent about noticing signs and concerns for things like suicide, which makes sense why suicidal ideation might have declined. People would have been having the social support to prevent them from making that attempt that would have been expressed in a search online. One of the big things we had in COVID-19 and our failure to not be prepared was misinformation, right? Everybody told you, well, the head of the FDA says now, misinformation kills more people than anything else. Now that may or may not be misinformation. But what they don't tell you is they don't talk about the substance of it. So how do we define it? And so I'm gonna show you an example of a study we did in JAMA Internal Medicine topic where we looked at misinformation about face masks. Everybody knows there was a study that came out, a randomized controlled trial that showed that face masks did not protect the wearer or the community from infection, cloth face masks or reusable face masks. And here we looked at people discussing that study on Facebook. And so we had 3 outcomes. They could claim the mask harms the wearer. Well, that study did not say that, right? It said they may not work. The study might have been underpowered. You could argue they work or they don't work. But saying they harm the wearer, that's definitely misinformation, right? You can see like Danish study proves the ineffectiveness and even harmfulness of wearing a mask. People might make conspiratorial claims. Like, that Bill Gates, he's trying to create a dystopia. And we can all agree, yeah, that's misinformation. And we can see people engage in a debate on this study just naturally. And we see what they do not make conspiratorial or do not make objectively false claims about the damn mask study on randomized control trial on face masks. And what do we find? We find that posts, yes, some posts did share misinformation and conspiratorial claims, but you can see here in this chart is that Facebook accounts that were affected by automation, where we know they're within a network where they're a bot, where they're being controlled by a third party, and they're making posts within milliseconds of each other, sharing the exact same content. Those were 2 and 2.5 times more likely to make claims that said face masks harm the wearer or make conspiratorial claims about face masks, both things to be objectively false. And it summarizes into a majority of Facebook posts espousing misinformation about face masks and their effectiveness came from bots, not people. And so it changes our perspective. We could get rid of bots, and that could solve a lot of problems instead of trying to censoring what real people think and how real people ask questions and seek out help and guidance. But it's a political question. Why do we have bots? I'll tell you 1 or 2 reasons, and you can help us solve this bot problem because it's still not resolved. And that is politicians maybe need them. So they look popular on Facebook and Twitter or elsewhere during their campaigns. So it's like the nuclear weapon, we gotta have it. And social media companies don't want to purge them with bots because, man, Facebook would be a boring, boring place if it was only my grandma talking about knitting. So we need them. We need people designing content that's sexy, addictive, gets our attention. And by doing that, a majority of misinformation, objective misinformation, things that there's no evidence for, conspiratorial claims, this pure craziness, the majority of that is driven by these bots. One of the things kind of related, but things like COVID are happening all the time. We're aware of COVID because it was one of the biggest. We're aware of like the Great Recession. But these things happen a lot. And what's the one thing that's one of the biggest things going? People using at-home therapeutics like CBD. And buddy, everybody wants it. Here's people looking online about how to get it. I think we estimated that there's I think it was 10 million people search a month, or 10 million searches a month about CBD products and how to use them or get them. Here you can see each state is going up everywhere. It's happening nationally. We can also see how they're using it. So we can compare it to other things, not just to contextualize, we can compare it to other things to let you know the context. It's like I tell you there's a lot of searches. We don't know what that means, but I tell you, whoa, the one thing I think about all the time, diet. For every 2 searches about diet, there's 1 for CBD. CBD is more popular than veganism, as popular as yoga, more popular than marijuana, exercise, vaccination, meditation, other alternative therapies like apple cider vinegar. Everybody knows that works. And acupuncture. And so it's an insanely huge problem. And when we published a study not long later, the then FDA commissioner, Scott Gottlieb, was given testimony before Congress, and he said this. He said the FDA, and I remember, we recorded it and we put it in our media materials, that, he was asked this, and I think the senator was like, now listen here, we know this is a great miracle drug. We don't want to say anything bad about it. But what if some people are misusing it? We got to be careful here. And Scott Gottlieb's like, listen, we would do something if patients with diagnosable conditions were influenced to use CBD as a therapeutic. Now, we don't regulate, the open market of wellness products. We regulate therapeutics. And if they're using it in that way, then we'll do something. And I thought, you know what? I want to give him an answer. I like his Tom Ford suits, but I also want to give him an answer. And so we did. And so we turned to Reddit forum RCBD, and we looked at, here's example posts of people talking about using CBD. You can see, the first posts are like, can anybody help me find a way to get CBD products in Indiana? But they're using it for anxiety. We can see people talking about, oh, how to get it. I want to know what I want to learn about these products. And so what we can see is that, some people are using it for wellness, like anxiety. But you can see in the bottom two rows, some people are using it for diagnosable conditions. They're using it for conditions where we have therapeutics with known effectiveness that could ameliorate their concerns or even resolve their condition entirely. Like this person was taking it for generalized anxiety disorder. This other person was taking it for ADHD diagnosis. And so we can see that. We can see taking it for wellness. And it turns out, some wellness was pretty popular, right? Scott Cloud was right. A lot of people use it for wellness. 30% of posts talk about using it for mental health wellness, and about 1% of posts talk about physical wellness. Like, I feel better, I can exercise better, I'm losing weight, it's like a supplement. I'm taking a supplement. But the vast majority of people, nearly 2/3 of people use it to treat a diagnosable condition. Examples of people using it to like replace their Coumadin. I have AFib, and I'm worried about rate control. I don't want to have a stroke. So you know what? The blood thinner, I don't like that. I cut myself shaving and I bleed. I'm going to take the CBD. That's better. And they do this for a host of conditions: psychiatric, orthopedic, sleep, neurological, GI, oral health. And we can see them using it at different rates, and so it helps educate not only regulators about what they should do, but maybe doctors should think about this. And I don't know how many, cardiologists think, like, when I educate my patient on what to do with an AFib diagnosis, a relatively common diagnosis among the very elderly, but I should also say, don't stop your blood thinner to use CBD. You probably don't even think to bring it up. And so, here's an example of how this product is interfering with the market. We answered Scott Gottlieb, but he left and went to work for the industry, so nothing happened. The fourth way I can talk about this, though, is how you can make a difference, because some things you can do, and it doesn't depend on Scott Gottlieb, right? You can do things directly that impact the outcome. Now, I want to give you some examples of how we've done this, and I don't mean this in a braggadocious way. I'm showing these examples to say this is simple. You can do it too. Just by listening to the public, this is the kind of echo effects we can have. One example is Charlie Sheen. Right? I remember I was in this office actually when he got diagnosed, and I have a TV over here, and I like to pretend I watch smarter TV, but I had the Today Show on, and I saw it and I thought, this is interesting. Matt Lauer didn't ask him who should get tested. What's the risk factors for HIV? What can we do to improve public health? He didn't ask these questions. Charlie Sheen didn't have that to offer. And I went and looked at the media reports, and nobody talked about it. The Hollywood Reporter published about his sex dungeon at his Malibu mansion. Right? We didn't talk about public health. And people kind of standoffish, but I also realized, this isn't Magic Johnson. I'm barely old enough to remember that. And back then, people were like, can you play basketball with him? Can you shake his hand? It's different now. People know that, you should get tested if you engage in high-risk behaviors. Testing's available. And people know that you should wear condoms. And condoms can help protect you during sexual interactions from acquiring the disease. People know these things. Sure enough, generic interest in HIV reached all-time highs. There's news stories in blue, searches in black. You can see all-time high. There's a 400% increase in searches, a 260% increase in news. And of course, people are talking about it. But are they talking about it in the way I talked about, where we know what to do? And the answer is yes. I want you to ignore the first one with me first, but you can see people searching for HIV symptoms queries in the middle column there, the middle panel there. And you can see like there's a pronounced increase. These are searches by the hour. The time he made the disclosure on the Day Show, you can see an immediate spike. You can see that spike last about 3 days. in the column and in section G there. We can see people searching about how to get tested. Again, immediately, he announces, people like, maybe I should get tested. Should I go get a test? And that effect, again, lasting about 3 days. If you go up to the top row, you can see condoms. And people at 8 a.m. watching the Today Show wasn't like, I need to go buy condoms. But that night, maybe there's a reason why, they were like, you know what? Maybe I should think about condoms. And they go online and think about how to buy condoms. And you can see that effect lasted about a day. Now, our study was very popular in the media, got a lot of attention. Charlie Sheen promoted it. We did some work on it to try to promote HIV testing and also condoms with 2 different companies. And I remember one of the companies reached out to us and they said, John, we read your study and we have an agreement with Walgreens, and that's Sure, the parent company. They're the makers of Quick, and they even make the clinical HIV testing kits that are used in the clinic. But they have an over-the-counter one. They sell it everywhere. But Walgreens gives them barcode data, and so they get data on their weekly sales, and the data is delayed. And he's like, John, we read your study, and we're going to get data in a few weeks, and we want to know. We're going to be able to see if what you said was true, if there was an increase. And he gave us that data, and yes, you can see there in red, actual testing went up. And again, the data is not aggregated by hour or day, it's by week, but actual testing sales went up. But I was more interested in this. And that is, Charlie Sheen was the all-time high in people going online and learning about testing, and people walking into Walgreens and buying an HIV testing kit. The 11th all-time high is us. Our study, simply responding to the public and saying, we hear your voice, we understand your need, and echoing that in the media, there was a statistically significant increase in HIV testing sales, 11th all-time high. We didn't need $1 billion. We didn't need to plan for 5 years. We just did the work while it was timely, responded to the public and let the public know that we were listening. And so one of the ways we hope to facilitate more of that type of work is by, building out a platform where people can monitor these. And so here's an example of where we show that our data can actually forecast very well the Walgreens data that Sure has for their Quick sales. And we can do a very good job of that. And it's something we're hopefully excited about doing in the future. Let me give you another example. Pokemon Go. Everybody remembers Pokemon Go, and it was all the rage. I think Davey still lives in a Pokemon Go universe. And everybody's like, this is great. Even smart people like Atul B was like, this is great. Thousands of people are walking. And I remember seeing all this thinking like, I don't play Pokemon Go, but if I did, we'll jump in a fancy 5 sports car and rush around and get them all before everybody else could, right? Because I can be faster than them. And so we wondered what would happen. And so literally a week after Pokemon Go was launched, we looked. And what's one thing people like to do on social media? They like to tattle. And so 350,000 people went online and tattled and said, look, I see a driver or a passenger or pedestrian playing Pokemon Go and interacting with cars. Like this person, my mom just legit stopped the car in the middle of the road to catch a Pokemon. I mean, my sis drive me around to find Pokemon. I got my friends doing this. I just saw a kid get clipped by a car trying to catch a Pokemon where it was out in the road. And so we can see that. We can see that, 33% of all Pokemon Go social media posts that week were not about how great the product was. They were about how drivers, passengers, and pedestrians were distracted by the game and playing the game, engaging in driving. Now, Niantic, the parent company, did not want to harm people. So the CEO reached out or his assistant and scheduled a meeting, and we talked to them, and they set a precedent. And they restricted options for this specific augmented reality game that limited the ability to play it when you had been at supposed driving speeds. The game was no longer accessible to you. And actually that precedent that they initiated based on our study was codified into some state legislators. And so again, we can solve a problem and resolve it. And Davey, you're a level 42 Pokemon trainer, you're telling me in the chat, and I'm glad you're not going to get hit by a car doing it, or you're less likely to. And I think that's what this study was able to do. And I don't think, I know it's what it did. Made a difference. I'll give you an example of another one we did on 13 Reasons Why. And when 13, everybody's here heard of the program on Netflix. When it came out, everybody's like, this is a great program. It's got great writing. All the media was like, it's going to start a conversation. My friend Howard Kopelitz over at the Child Mind Institute here on the Today Show talking about our study. He was like, I don't know. There's these WHO guidelines, right? And they say, don't talk about suicide a lot in the media, especially don't show the modality of suicide, especially don't show suicide as a way to resolve problems. Yet, how did the show present it? The very opening scenes of the show, the protagonist character, she's already dead by suicide. And you see a zoom in memorialization of her locker. And you learn suicide solved all her problems. Her boyfriend regrets not being a great boyfriend. Her parents regret not being great parents. Her friends love her more. Her enemies are no longer her enemies, and they regret and they love her now. And they even show the suicide act and the means of the suicide and dwell on it for many, many minutes. Knowing that, we quickly did a study just a few days after the release. And here we see people searching for suicide. And yes, suicide queries went up and they were higher than expected. And we can see the specific types of queries people were making. Like the search, how to commit suicide increased 30%. How to suicide, how to kill yourself went up 10%. People actually hurting themselves and engaging in a suicide attempt because of a program on TV. Now, when we did our study, we expected people would see this hurt and try to help. Unfortunately, they didn't, because this top-down model where we're the experts has corrupted our thinking so much we can't respond to data even when it hits us in the face. And so they see our study and go, look, President of the Society of Behavioral Medicine, it doesn't demonstrate suicides are going up, it just shows that people are interested in the program. You know, we don't need to get freaked out about this. It's a great show. I like it. I love the writing. Don't you worry. I'm an expert. I know this isn't a problem. Data doesn't tell me. The best we could do is get Netflix to add a warning to the program following our study at the beginning of the program, thanks to the Child Mind Institute and advocacy. But it took 646 days for these top-down experts to find confirmatory evidence where they replicated our study using death registry data or ER admission data to see that suicides actually were going up and attempted suicides were going up. 646 days. We allowed this harm to persist because we had to wait. We had to wait, find a funder, write a proposal, get funded. We had to wait for our top-down model to help us. And it's one of the biggest failures of our career that we didn't get this fixed. And we wrote about it later. And we said, what's it matter? When these studies came out in JAMA Psychiatry and another journal, we wrote back and we said, who cares? You're just putting italics on a piece of paper. The harm's already done, and you can't put Humpty Dumpty back together again. We got to change our perspective, and we got to rely on a public health needs-driven research ecosystem to identify the needs, identify the harms, ameliorate those harms, elevate benefits, and improve public health in a demonstrated way where research can have a direct impact on the outcomes. One of the ways we can do this is not everybody's going to go back to school and become a data scientist like me. I understand that. So how do we solve these systemic problems? Is we use existing technologies and we make existing technologies available to the public at large. I'm going to show you now some stuff you've seen in news lately, and about how it works, and around natural language processing and generative AI, not ChatGPT. Firth, J.R. Firth, a famous linguist, said in 1954, he died not long thereafter, said, "You shall know a word by the company it keeps." And we're going to learn about how things like ChatGPT work and how the underpinnings of that will help us. And we're going to do that by using this principle from J.R. Firth and some of the underpinning technologies behind things like ChatGPT. And you can see this principle exercised a lot. I'm going to show you an example sentence. I'm not going to read it for you, but there's some jerk in a red blank almost hit me. What is it with involved men and the midlife crisis Italian sports cars? And there's a blank there. So you can fill in the blank. Will you be 100% right? No, not all the time, but you'll probabilistically be right. And you could be like a red Italian sports car, midlife crisis. Oh, what's the primary color? What's the manufacturer color for this company? Red, Ferrari. I can know these things. And if I'm wrong, I'm guessing other brand names of sports cars. I'm getting kind of close. I'm discovering a similar phenomenon. How can public health use these technologies? These are called word embeddings. And so we're going to demonstrate how we can do it using discovering products. Now, you could use this in any context. We're going to discover, this is simply because it was funded by the FDA, and we did work on products. Zip, this is an e-cig, a vape device. And you can see here, we're showing the context of how it's used on a post on social media. This is Reddit. And here's people talking about Zip, and you see the words around it. And if I know Zip is a word, I can look for words that are used in a similar context, and I bet you they're also vaping products. And that's what we did. We trained a word embedding on 20 million Reddit posts about vaping. And you take a product we know, like Eon Smoke, and we can discover Zip, Eon, Sif, C-Pods, Loon, Mango, My Blue, Zalt. And we can see that these words that are most likely to be similar to the same context are also e-cigarette products. Here's another example of how that works. We take a term like PAX. We discovered PAX because we knew about a product called Volcano. And yes, PAX is a brand or product related to vaping. It's sold in the United States. You can use it with nicotine. You can use it with CBD, and you can use it with cannabis. And it's actually been around since August 2012. And it's been posted about 165,000 times, even though this was not included in any known list of products by the FDA. We're able to discover the product, know how popular the product is. And we can see this happening. Here's another example of this. I won't dwell on this, but we can see how we could use this, where we can see like what's popular. And we can see products that are becoming most popular overall, becoming popular recently, like Mati is very popular recently. I've never heard of it until we did this study. EQ, very popular now. What products are getting very popular right now? Dynavape, Views, Hyde, Halo. And so we can understand this marketplace. We can understand what they're using. Think of how you could use this technology in a lot of situations, like what therapeutics patients are taking or substituting, or what the needs of the public are. You could take a needs-driven word and see like what other needs come up in their data. You could see that type of data. So that's the underpinning. One of the underpinnings of ChatGPT is word embeddings. So we're going to talk about how to use generative AI. And we recently did a study in JAMA Internal Medicine on how to use generative AI to help the public. And we focused on patient questions. We did a study that did three things that were relatively unique. We used real questions from real doctors. Well, first, let me say this. Patient questions, patient messages. How many articles have been published in JAMA or JAMA Internal Medicine on patient messages? And the answer is one. And it was one study, and it was on how do we reduce patient messages because they bother our doctors. We've got to get that number down. And it was about an intervention to do that. We don't really talk about what are the needs? Are the needs being met? How do we help these people? Generative AI makes that possible. So we want to evaluate generative AI for that potential benefit. And so we did three things in our study that was relatively unique. We used real questions from real doctors. Real questions and real doctors' responses. That's hard to do. Nobody, no CMO wants to share this type of data because they won't be the CMO very much longer when they show that the response rate is low and the response quality is bad. Instead of typically in these frameworks, we ask the person who posed the question to evaluate if they're satisfied with the answer. Well, you can see the problem with that, right? Michael Jackson had the world's greatest cardiologist, so great, he hired him to leave his practice and become his personal physician. We know how that worked out for him. We need an expert. So we used healthcare professionals to evaluate the questions and evaluate the quality of the answers that they're getting from real doctors and also generative AI. The third thing we looked at was empathy, because it doesn't matter just what you say, but how you say it. Everybody knows that who's ever been in a relationship. And so we evaluate these three things. I'll show you some examples here. Here's an example of an actual question that we had. This person got sick 3 or 4 weeks ago. They got a lingering cough. You can read it, but I'll summarize it here for you. They realize they're sick. They've been wheezing. They're worried about it. It's not resolving. Should they be worried about this? I feel good otherwise. But it hasn't happened to them before. They don't want to know. And they're worried about getting fucked up lungs. And that is a very bad outcome. We don't want that to happen. We want to help them. Now, here's a response that was generated or written. And it says it's common to have residual cough after you get sick. It's called postnasal drip. Don't worry about it. Try some pseudoephedrine to dry it up. It just takes time. If it gets worse at night, it's possible you got low-grade asthma. You might want to get an inhaler. Here's a response. It's always a good idea to pay attention to your symptoms. Lingering cough, that's worrisome. You might want to be worried. You might want to see a doctor, talk to the doctor. Here's some things you can do, though. You can drink plenty of fluids. That'll help. Use a humidifier. That'll help. Avoid irritants like tobacco smoke or strong perfusion. Try over-the-counter medications like cough suppressant or expectorants, right? To help relieve your cough. Practice good hygiene. You don't want to spread whatever you have. And if it persists, you have other signs, you might want to go see a doctor. And so we have these two responses there. You might have guessed ChatGPT wrote the good one. And yeah, even though these answers were, clinically relevant, and again, I wasn't an evaluator, licensed clinicians were, there was clearly a disparity in the quality. Our doctors preferred ChatGPT, 2 out of 3 of them did when they evaluated. They gave it a mean score of 4 on quality, which stood for a good response, from very poor to very good. And they scored it empathetic, 3 on a 5 scale for empathy, compared to the doctor's response, which got a lower score for quality, which was rated as between good and very good and somewhat empathetic. But these disparities become larger in many cases. Here's someone, they got a Holter monitor result, and they just got the results in their inbox, and they're like, what do I do? They need to read this. They're worried about it. And here's the problem I'm having, right? I got these run over summary of the results. What do I do? What does it mean? Well, this is one response I got from a doctor. And this is a response they got from generative AI. All our doctors preferred the generative AI. All gave it a score of very good quality. All gave it a score of being empathetic compared to being adequate from the doctor. Because the results were benign. It wasn't an emergency. And being unempathetic, the lowest on empathy. In summary, looking at hundreds of question-answer exchanges from real patients and real doctors, 79% of physicians preferred ChatGPT to a physician-authored response, of our physician evaluators preferred it. And here you can see the distribution of those scores for quality and empathy, from very good to very good. And you see, like ChatGPT, the modal outcome is to be good or very good at quality, and physicians, they're better than acceptable, but it's normally distributed. Some docs give poor responses, and ChatGPT rarely does. When it comes to empathy, the AI outperforms substantially. Much more likely the modal responses to be empathetic or very empathetic compared to the modal response for doctors to be not empathetic at all. Now, someone might say, well, John, that's because the doc can't type that fast and get it longer. it's got to do with the length. No, it's not just length. Here we're comparing responses that get longer and longer, comparing equally long human-generated responses to equally long AI-generated responses, and the AI still outperforms, still does better. And so we can use emerging technologies to build out systems to resolve problems like word embeddings, the architecture of generative AI, or like generative AI itself. And we're continuing to work in this domain now. We actually build our own model that's different than ChatGPT and trained to answer patient questions, and we'll be evaluating it soon. The other way is to get the tools in people's hands. We've got to get the tools out there. We're briefly running short on time. We got to equip people to be able to do this stuff. You know, ChatGPT is great. You know, that's the technology everybody can use. Word embeddings are accessible somewhat. You can actually get them from OpenAI. But yeah, we got to get more tools out there. I'll show you one example, and that is predicting infectious disease outbreaks. You know, everybody remembers Google flu trends in the published study in Nature, one of those read studies of all time. And yeah, 3 months later, it went off the rails. And some friends of mine at New York City Department of Health and Mental Hygiene wrote a paper saying, "Well, it's not good." I'll show you some data here. You can see in, here's the CDC data for influenza-like illness in black, Google flu trends in red. You can see like, that's when they started using it at the very far left of this time series. And you see, whoa, it goes off the marks pretty quickly. It is not doing that good. And you can see it also performed poorly in other time series where like in 2012, 2013, it way over predicted how many people have flu and would cause a response that was unnecessary, right? But we created an alternative. And our alternative here is in blue. And our alternative outperformed Google substantially. And I think it's important to understand that you don't need to be a data scientist expert to understand how to evaluate these platforms. Too often we read the abstract and go, that's true. Google flu trends was what? Had to be a fancy algorithm, right? It was a simple linear regression. One outcome, influenza-like illness, and one predictive coefficient, the mean trend for the top 100 most correlated queries. That's it. So we built a model that was more adaptive, you know, using a lasso technique, machine learning technique, where we have each search term. And we constrained our model with the same 100 queries that Google would use. And you can see like indoor driving range is the most correlated thing with influenza-like illness in terms of raw correlation. But you can see our model knew to discount it to 0, even though Google flu trends would always listen to it. Our model knew to discount other things. And so you can, an interesting way to evaluate this model is to look at the 2012, 2013 influenza season, and you can see like, look, signs of the flu, we ignored that in our model for a long, long time. No human intervention. We're not telling it these are relevant, these aren't. But we gave it a lot of weight in 2013. Things that we were giving weight to, we discounted those. Like, for example, what is the flu? Discounted. Because, you know, it could be driven by media, it could be an indicative report. And so all this is happening automatically. And so we can build a forecasting system to understand the needs of the public and make the system accessible to the public for their real-time use, you know, build platforms to do it. One of the cool ways we can do this is we can not only just do that for infectious diseases, we can do it for many outcomes. BRFIS, everybody's heard of the BRFIS. It's the big, you know, 350,000 person survey the CDC does to try to understand the needs of the public. Here's the original paper announcing BRFIS. BRFIS is typically analyzed what? In aggregate. These are the results for this year. These are results for another year. Let's compare them. Let's compare states. But if you read the original paper said the goal was to do across states and across time. If you look at the raw data, the way interviewing works is you have a staff of team, and they're working. They're doing interviews trying to reach their quota. And you can see they do a lot of interviews early in the month and some later in the month. But even later in the month, they're still collecting as many as, you know, a couple thousand interviews a day. So we actually have daily data from Burfus. And so remember how I told you early on, we could see things like mental health problems? Here's serious psychological distress, the Kessler. Now think about how 13 or more days in black. We know this predicts all-cause mortality. We know this predicts bad outcomes. I can predict that outcome now using alternative data from online in red and show a strong correlation with that. And I can actually build a platform that can provide these data, not with a 1 or 2 year delay or a forever delay, which is often the standard in public health, but real time. We can equip scientists to use real-time analysis engines to make decisions about how they resource public health and how they identify and respond to needs. And that's something we've written about before, about how we can build these. And this is a great editorial, well, I shouldn't say great, we wrote it. Editorial we wrote in JAMA about how to use this type of data. I want to thank you all for coming, and thanks to the people who's funded this research over time. And we'll open it up for questions.
Thanks, John. We have a few moments, but that was a tour de force. Anybody have any questions, thoughts, criticisms? He takes them well.
Yeah.
Hi, John. This is Marcelo from the J. Craig Venter Institute. Super interesting research. I was curious to know a little more in the methodology in terms of where's the data from and how reliable the data, and how do you sort to make the data reliable? It's so fascinating to do this sort of inversion of projects that you're doing, but I'm just so curious to know more about the data source.
We use entirely public data. Like for example, Reddit, we download their data in real time. So we have every Reddit post ever. There used to be a public access for Reddit that is closed now recently because of OpenAI and other companies scraping the data. So this is evolving. The marketplace always evolves, right? I mean, some MySpace was popular and then people moved to Facebook, and then Facebook's popular and now people are migrating to Twitter, right? So, things happen, and we just use data that's publicly available and try to use APIs to pull the data there. In terms of methodology, I would encourage people to go read a famous Gary King paper on the small of big data science. I think it was in Science. And a lot of people think of this stuff as esoteric, but the core principles of quality science that is intended to produce reliable and replicable results are the same. And so, we use techniques that, we don't talk a lot about the techniques in these types of talks because, we're focused on the outcomes about how you can use it, but we use techniques that are pretty straightforward. I mean, just common, ordinary techniques, nothing fancy.
Yeah, I definitely would like to follow up with you about it. Your talk just made me think about several questions, but more like future biological ideas or, interesting questions. But one comment is the concept of long COVID that is becoming super important. And the problem that there is that we don't really know how to diagnose and what it is. So for example, I work a lot in the oral aspect and the immune aspect. So there's loss of taste and loss of smell and other aspects, but we don't really know, we don't have a full analysis. And I see an opportunity there for models like yours to investigate and compile, and sort of create endotypic analysis of this.
Yeah, exactly. I'm sharing a screen now of a forum on Reddit of COVID lawn haulers where people are talking about their COVID. And so here you can see, we have this data from this Reddit. I can't quote correctly the numbers off the top of my head, but we have a few 100,000 observations on different people where they talk about their COVID symptoms and what's going on with their life. And we can learn about them, and we can learn their needs and have this cohort that is naturally occurring. Yeah. Where no clinic has more than like a few hundred long COVID people, right? Like, how many do we have at UCSD, Dave? Not that many, it's just, now we can have 100,000 patients where we observe what they're thinking when they're not lying to us, and they're talking to their friends, and when they're thinking it. And, They're bringing it up when it's happening. I'll say that. Other way to think about it is, I gave you a talk about how we can use this to understand the public health. You can also use this to understand us as the end researchers, right? Like, how do we, most people use Twitter to read medical articles. You got to know that's the water cooler, right? You got to know what people are talking about. You don't want to be the guy that doesn't know about that study in JAMA Internal Medicine yesterday on how Republicans are bad and Democrats are good, right? You might have missed that study. It came out yesterday, 10 a.m., right? But you want to know about it. And so they use this. We're available on these same platforms to understand us. You could probably use these technologies to actually generate hypotheses based on clinical experiences that physicians are having in their practice, and pick out, because all hypotheses are based on some data, and actually use this to create clinical hypotheses, for example, by changing the population from the patients to the providers.
Yeah.
There's a host of things you can do with this that are really neat.
Fascinating perspective. Thank you.
All right. Any other questions?
Okay. I think we're good. I
Okay.
think we have an advertisement, right, Steve?
Yeah, I'm just, 1 second. All right, so just a reminder for everyone. So this is an ongoing monthly seminar series. Next month, we're going to have Rebecca Fielding Miller speaking on Tuesday, August 29th from 12:30 to 1:30 p.m. Those invites will be coming out shortly, so please do attend if you can. And thanks again for being here today, John. Great talk today. I really do appreciate you being here, and happy to have you back whenever.